Sub-study of patients in the pooled ORION 10 and the ORION 11 on patients with prior myocardial infarction. Again, benefits seen in patients with recent MI or non or remote MI in terms of the LDL goals and the LDL cholesterol values which were achieved. It has a favorable safety profile. We have a maximum exposure of 6.8 years, and the commonest side effect that is seen in most of these studies was an injection site reaction. No clinically significant drug interactions are expected with this. There is mild to moderate hepatic impairment that is seen in a small subset of patients. The ORION 8 studied the long-term safety of twice-yearly inclisiran in high cardiovascular risk patients. The side effects and the profiles remain the same, and the commonest were the injection site reactions. What about inclisiran in Asian patients with atherosclerotic vascular disease or high risk of atherosclerotic vascular disease? This is a multi-center randomized double-blind parallel group placebo-controlled trial. There was a significant reduction in the LDL cholesterol from baseline with inclisiran, which is almost 57% as compared to others. And the follow-up was almost for a year of follow-up in these patients. So the inclisiran, irrespective of the patient population, has a definitive benefit in reducing the LDL cholesterol values. People talk about cardiovascular outcomes. Yes, there are cardiovascular outcome data with evolocumab, which shows a 23% reduction in events. What about inclisiran? This is not a final. This is not an outcome study, but if you look at the pooled patient level analysis that is there, it showed a 26% reduction in the composite MACE, fewer MACE as compared to placebo, and numerically lower events of myocardial infarction and stroke in those patients who were randomized to inclisiran. There are various studies which are coming up, and in 2026, 2027, the VICTORION-1 Prevent, VICTORION-2 Prevent, and the VICTORION Plaque studies on plaque burden should be released and give us a better idea about what's happening in this space as far as reduction in plaque volumes and cardiovascular outcome data with inclisiran is concerned. The advantage is that it's twice yearly injection. You give it a day 1, day 90, and subsequently once in 6 months. The disadvantage being, of course, the cost, and of course, I think the various players involved are looking at reducing the cost levels. In terms of a future evolution of lipid-lowering therapies, we are looking at newer targets, looking at lipoprotein A values, and there are newer drugs which are now being in the phase 2 studies on lipoprotein A. They have been studied in the US. There's one drug by Eli Lilly and I think one by AstraZeneca. So these are two drugs in the pipeline for LPA reduction, though evolocumab has been shown to reduce the LPA levels in a certain subset of patients. This is an interesting study, just to complete my talk. This is a Polish study on patients with high risk of diabetes with dyslipidemia and the need for lipid-lowering therapy. Their drug of choice in that study was pravastatin. Why pravastatin? Because they studied that it was the drug with the least effect on HbA1c. So again, depending upon what level of reduction you want in the values of the LDL, you start off with a single drug, add on ezetimibe, go on to bempedoic acid, and then, of course, PCSK9 modulations in those patients where you require a significant reduction of the LDL cholesterol values. Two separate guidelines looking at a common goal of therapy, the ACC and the AHA guidelines, and the European Society of Cardiology guidelines. Both suggest high-dose statins first, ezetimibe as the second drug of choice, and then subsequently, when these drugs do not work, add PCSK9 inhibitors. Do you have a role for adding PCSK9 inhibitors in high-risk patients? Well, we still don't have enough data on that. But in certain high-risk populations where you want a rapid reduction of the LDL values, and in acute coronary syndromes, there have been studies of using PCSK9 inhibitors to reduce the levels of LDL. And as you know, Indians are, in general, we are intolerant to a lot of side effects. Moment you raise the statin dose, patients come back with some complaint or the other, and they drop treatment. And that becomes the biggest bane in our treatment protocols, where we are unable to convince patients to bypass the side effects and continue medications in their benefit. The Lipid Association Expert Consensus Statement 2020, the Indian Guidelines on Dyslipidemia, high-intensity statin, LDL cholesterol more than 50, add ezetimibe, LDL cholesterol more than 50, consider bempedoic acid, PCSK9 inhibitors, monoclonal antibodies. So the key takeaways here is that 1 in 10 patients will have a second MI, stroke, or cardiovascular death within the first 100 days after experiencing an MI. Intensive lipid-lowering therapy as early as 24 hours after the index event or after the index procedure, and target LDL levels should be reached within 30 days. Regression of atheroma volume slows down the progress of atherosclerotic disease, improves the outcomes. Inclisiran plus statin medication in post-ACS patients rapidly lower the LDL cholesterol and thereby help to reduce the risk of recurrent events. Thank you very much.